Hi everyone. Today we're going to talk about anti-hypertensive pharmacology. We're going to go through a couple different definitions quickly and then mostly spend our time talking about the drugs. Of course, I do want to talk a little bit about the new guidelines. So the definition of hypertension is generally blood pressure over 140/90, and most of you guys probably know this already. The goal may change or be stricter depending on if somebody has a comorbidity. It's a really common disease with many millions of people being affected. So the odds are, no matter what type of practice you work in, you're going to encounter somebody with hypertension at some point in your career. So that is really an important kind of cornerstone of medicine to know how to treat it. And hypertension is also a factor of just aging. So our aging population, even if you're an older, healthy person, your blood vessels just don't respond as well, and your cardiovascular system isn't as tip-top shape as it used to be, regardless of how active you are. And that can cause hypertension just from aging too, even if you have no other risk factors. So it's something we see with our older population more so, but it certainly is something to consider in younger population. Especially there's some caveats with pregnant women as well, as again, most of you guys are probably pretty familiar with that already. High blood pressure, also oftentimes called the silent killer. In case you're wondering, keeping blood pressure within goal has been shown to decrease stroke risk by 45%, decrease myocardial infarction by 25%, and decrease heart failure risk of developing it by 50%. And then you can see the different complications I have here based on organ systems. So hypertension causes a lot of microvascular complications, but then of course you can also have some macrovascular complications too, such as developing heart failure over time, or organ failure like kidney disease and kidney failure over time due to excessive blood pressure. So because of this, we really want to protect all those organs throughout the duration of our patients' lives, and so that's why managing blood pressure is so important. Diagnosing somebody, usually there's periodic screening for anyone over 21 is what's recommended. The patient should be seated for at least 5 minutes. I think this is really important. If somebody just walked across a lobby, or they walk down a hallway or something like that, and they sit down and they immediately get their blood pressure checked, the odds of it being super accurate aren't good. So if that is the case, if you're ever reviewing something and you're questioning a high blood pressure result, feel free to ask your nursing staff or whoever took the blood pressure to consider taking it again if they didn't let the patient rest for a little bit. Appropriate cuff sizes, taking the blood pressure twice, separated by at least 2 minutes, and then the average blood pressure on 2 separate visits is required to diagnose blood pressure accurately. One visit blood pressure is not necessarily indicative of hypertension. It might be concerning and it might be something we want to watch, but at the end of the day, you still have to consider that white coat syndrome, and that patient might have been anxious or stressed out for something that we can't control, some other factor going on in their life that we may or may not know about. So at the end of the day, you have to be aware of those situations and try and get another reading maybe on a day where they're not so stressed out, or try and do some home readings potentially with a home blood pressure monitoring system. Essential hypertension represents about 90% of the cases, which really means it doesn't have any necessarily identifiable cause, usually linked to some correlative things like obesity, possibly excessive amounts of dietary sodium. Secondary hypertension means there's some other cause behind what's causing the blood pressure, and I listed some things there. So mostly we're going to be talking about essential hypertension here. Of course, in your patient population, you have pregnancy as sort of a cause, if you will. I don't know if you would technically consider that a secondary hypertension, but you certainly could, because usually if somebody's preeclampsic or something, delivering the baby is the best way to stop that process from going on. So certainly that's an issue that some women will get during pregnancy but not get any other time. So definitely special to that population compared to some others. But we'll talk about it as essential hypertension because it's really the same thing. We're going to treat it pretty much the same with some slight differences and some preferred agents in pregnant patients. Our first step is always non-pharmacologic therapy. So sodium is an important thing to consider restricting if you need to. Fluid retention is a big component of hypertension. So if somebody is hypertensive, it's good that they watch their sodium. Dietitians can help with stuff like that too, so I highly recommend taking advantage of that if you think that's something that would help the patient. Maintaining healthy body weight can be positive for lowering blood pressure. Having a talk about caffeine intake. Caffeine, especially if they drink it every day and drink large amounts, can definitely increase blood pressure. Exercising can lower blood pressure. Life stressors, removing yourself from stressful situations, learning to cope with stress, those types of things can help lower blood pressure. Smoking is related to high blood pressure, so if we have some smoking cessation type interventions, moderate alcohol is also associated sometimes with high blood pressure. So either cutting back to a moderate amount if they're drinking a lot, or cutting back to a low amount of alcohol if you think that's a modifiable risk factor. Removing medications. Sorry, I should have actually said, I kind of misspoke there. Moderate ethanol consumption is associated with better blood pressure outcomes. So that means like high alcohol consumption is usually associated with more. So if you can get your patient on what we'd consider like a moderate amount, that would be better. Removing medications. Chronic non-steroidal anti-inflammatory use is also associated with hypertension. The reason being is because your body has good housekeeping prostaglandins that promote vasodilation, and that works within your blood vessels. And if you're constantly suppressing those with NSAIDs, the production of those prostaglandins, you can end up working against your body's natural vasodilation properties, and that can cause hypertension or contribute to hypertension over time. Okay, treatment goal. The 2017 guidelines basically say the goal is the same for everyone. These are the JNC guidelines, what used to be called JNC 7 way back when, and then JNC 8. Now they kind of just update it periodically and call it the year. Or the AHC or AHA guidelines is also what they're called too. Anyway, 2017 guidelines, goal is the same for everyone. It's less than 130/80. This is kind of new for this subset, is that this same goal for everyone. They used to have different criteria, and we'll talk about some of this here in a second. But some patients have, and I think in the guidelines they do kind of have a caveat saying older patients you could consider going with a less strict goal. I think one thing clinicians were struggling with elderly patients is trying to figure out a way to meet their blood pressure goal, but at the same time not over medicate them and not get dinged on core measures and things like that. Where if your results are being reviewed by an insurance company or something, they're like, hey, you deal with people who are over 60 and only 50% of your patients are at goal blood pressure. Well, if you increase the goal from 130/80 to 140/90, more patients get within goal. So there's been some arguments that just sometimes older patients are really hard to manage to get them to a tighter goal, and it just gets complicated with adding lots of meds on. So that's a little bit controversial. And then also same thing for somebody who's healthy. If somebody has no other things going on, do you really need to target 130/80, or is like if they're 135/86, is that okay? Most people would agree that if you're over 140/90, though, that's the treatment cutoff. So it's really that between 130 and 140 and between 80 and 90. So that really narrow range of systolic and diastolic blood pressure where there's a little bit of controversy. Okay, so when do we start an antihypertensive on a patient? We're going to talk about antihypertensives in detail, so don't worry. But just to give you an example and some of the thoughts behind the guidelines, if somebody has no CVD, which is cardiovascular disease, and has a 10-year atherosclerotic cardiovascular disease risk of less than 10%, if you don't know what this is, you can search this acronym and risk calculator, and it'll take you like American Heart's website or AHA's website. I can't remember. I think that's the same thing, but they're slightly different. Anyway, there's a bunch of calculators out there, and or heart.org. That's what I was thinking of. I think they have a calculator there. Anyway, just Google it and you'll find a number of different calculators out there. They all pretty much do the same thing. What they're looking at is a number of different variables, such as do you smoke? What's your blood pressure? Do you take medications for blood pressure? Do you have diabetes? What's your cholesterol look like? How old are you? And it looks at all those things, and based on that input, you get a risk score. Now, if your risk score is above 10%, that's considered high risk. That's usually the cutoff when it comes to a lot of these recommendations. But let's say you have a person who's got no cardiovascular disease, their risk score is under 10%. You wouldn't start any medications for blood pressure until their blood pressure is greater than 139/89. So again, this is, remember our goal is 130/80, but they would say that for that patient population, you should be focusing on lifestyle modification to get to goal, not medications. If you have cardiovascular disease or a 10-year risk greater than 10%, you want to start medications when the blood pressure gets above 129/79, and also for the following conditions. So people who have diabetes, chronic kidney disease, or are age 65 or older, they recommend starting that. And the reason being is because all those criteria have higher risks for other complications. So diabetes and hypertension kind of feed off each other, and you end up with high pressure in the microvascular systems, plus you end up with high glucose concentrations that can cause increased damage to blood vessels and the vasculature in those areas that we talked about at the beginning. Chronic kidney disease, you add blood pressure onto somebody who already has high blood pressure onto somebody who already has kidney disease, and you do generally try to manage it aggressively. You want to preserve whatever kidney function you have. If you're age 65 or older, again, older people have higher risk for things like MIs, stroke, and developing some of those complications. And so that's why they are put in that category. Again, that's a little controversial, or can we give our older patients a little bit of a break here? But current recommendations would say you should start an older person on a blood pressure medication when they're above 129 over 79. Controversial would be for people over 75 with just a 10-year risk of 10%. And again, that's that elderly controversial. Can those guys get a break? Those guys and gals, I should say, get a break because they are over 75. And again, it can be really hard to manage those types of patients. Oh, and then I put the risk calculator right here. Although I think this one might be a little bit out of date. Although it's changed over the years. And what's changed is probably the output number. The variables are all the same. So you can look at that link I have there. But I would just Google, like, again, AC CVD risk calculator, and you'll get something you'll get the most current one. It should be like the first hit you'll see. Considerations for individuating antihypertensive therapy. This slide and table shows you compelling indications. I'm not going to talk a ton about compelling indications because I think it gets a little out of scope of practice for this course, but just in case you're curious and how we make some decisions, like let's say you have a patient who comes in and they also have AFib, for example. Well, these are the preferred agents you would use for those types of patients. So we're going to talk about the guidelines and where they direct you for different medications. But if you do have what's considered a specific indication, or what used to be called compelling indications, you would direct your therapy that way. So like where's somebody with diabetes? It should be on here somewhere. And it's not. Well, it kind of sound foolish there, but okay, let's change gears. Let's look at pregnant patients. Here we go. Pregnancy, or at risk for pregnancy, and they show you the antihypertensive drugs that would be contraindicated there. So they're taking a different step with this column and saying, all right, you can basically use anything but these ones for them. And I think like diabetic patients aren't really on here because there are some preferred agents, but with diabetes, you can pretty much use everything. Renal vascular disease, you could maybe consider that like a diabetic patient getting to the point where they're at risk for something like that. But anyway, let's keep moving. If somebody doesn't have any really compelling, somebody doesn't have any compelling issues, any one of the 4 classes can be started. So we have 4 primary classes that I'm sure you guys as nurses are pretty familiar with all these drugs. They're all very popular classes of medication. So we have thiazide diuretics, long-acting dihydropyridine calcium channel blockers, and angiotensin converting enzyme inhibitors, or ACE inhibitors, and then their counterpart ARBs, or angiotensin 2 receptor blockers. Strategy for treating hypertension is basically mixing and matching off of these classes and not combining ACEs with ARBs. So there's been a lot of studies looking at can you combine an ACE and an ARB, and they've all shown that there's no added benefit and people have more side effects and risk for complications with that combination. So we don't combine those two, but everything else is fair game. So basically think of these as one category, these bottom 2, and it would be an either or, and we'll talk about where you make that decision here in a second. Alternate agents, beta blockers and alpha blockers are alternates. Beta blockers, I think a lot of people still think of those. Oh yeah, you take those for blood pressure. They're a first-line agent. They really have fallen out of favor as a first-line recommendation unless you have some sort of underlying CV disease, like if you have had an acute coronary event in the past, or if you have heart failure or something like that, they would consider that. But beta blockers just have an unfavorable side effect profile for a lot of patients, and that's why they've fallen off the initial recommendations. All right, let's talk about the renin, angiotensin, aldosterone system. Talk about the drugs a little bit more. So 3 drugs classes in this category, really 2 that we actually care about and one that's super rare. ACE inhibitors, ACE is angiotensin converting enzyme, and it converts angiotensin 1 to angiotensin 2. And the reason why that's nice, that's a nice pharmacologic target is because angiotensin 2 is a natural vasoconstrictor and causes, it's usually activated due to stress response in the body, and an overstimulation of the system causes an increase in angiotensin 2, which interacts with the angiotensin receptor, and you can see some of the effects here that they list out in sort of a scientific way. But basically what happens is you increase sensitivity to catecholamines, which causes vasoconstriction and other things. You basically increase your body's ability to react to a sympathetic nervous response, which can cause, over time, hypertension. And so ACE inhibitors have been shown to be one of the most successful medications for treating hypertension. They're fairly well tolerated by patients. If for some reason they aren't tolerated, the second choice are angiotensin receptor blockers, which they have here listed as AT1 blockers, and those block the actual receptor. So they bind onto this AT1 receptor tighter than angiotensin 2 would. So angiotensin 2 can't get in there and knock it off. And you get essentially the same effect. I mean, if you look at this logically, you're like, well, if I inhibit the formation of angiotensin 2 or I block its use, what's the difference? Well, actually, studies show that there's just the interesting thing is there's a lot more evidence out there for ACE inhibitors than ARBs. And that may be because ACE inhibitors are older, ACE inhibitors have been a mainstay of therapy, but I don't want to confuse you too much because they are an acceptable alternative. However, a lot of studies have shown that there does seem to be something of a better benefit with an ACE inhibitor than an ARB for certain conditions. For underlying essential for just basic hypertension, they're probably not a huge difference. However, ACE inhibitors generally are thought of as the better of the two if you can get by with them. So they're always usually tried first, and then if the patient doesn't tolerate it, ARBs are kind of the backup for them. But both are certainly common. And if somebody came in and was like, I've read that ACE inhibitors make everybody who takes them cough, I want to try an ARB to start with. If you wanted to prescribe an ARB right off the bat, you're certainly within your right to do so. Personally, I'd probably try an ACE inhibitor first, but again, that's just a personal preference. ARBs also have had some recent drug shortage issues and recalls affecting them, so they've been a little bit harder to get, some of the more generic, less expensive ones. So that's driven, I think, a lot of changes with this too. But the point is that they're interchangeable, they work in the same system, and they're highly effective for managing hypertension and also other aspects of cardiovascular disease as well. So major classes of drugs, again, we talked about these. The only ones we didn't talk about were direct renin inhibitors. Aldosterone antagonists I'm not going to spend a lot of time on because they don't really have a role in hypertension. They're pretty much just used for heart failure. And outside of that, really out of scope of practice for this course. So we'll talk about them briefly, but not a lot. ACE inhibitors. So ACE inhibitors are, again, first line for pretty much all of our major indications. They're a core component for a number of different treatment. And they generally end in pril, so it's pretty easy to recognize an ACE inhibitor. It's going to be lisinopril or enalapril or something like that. Class side effects, cough is 5 to 10%. And this is going to be the one that kind of sneaks up on somebody. They're all of a sudden realizing they're having this dry, non-productive cough, and they don't really know what causes it. They don't have a cold, they aren't sick, and then they tell you about it, and you're like, yeah, it's because we started your ACE inhibitor. Or you told them, and they're like, hey, you told me about this cough that might happen with the ACE inhibitor. It's bugging me a lot. Can we try something else? So that's a really common thing, especially considering how many people are on ACE inhibitors. Angioedema is, if you haven't talked about that in other courses, it's a systemic reaction. It's kind of like anaphylaxis, can cause throat swelling and tongue swelling and can obstruct the airway. It's fatal in some cases, so we take it really seriously. It's really rare. However, there are so many people who take ACE inhibitors. I mean, you've got tens of millions of people in the country that take ACE inhibitors. So you're going to see angioedema fairly often relative to, how many people are on the medication. So again, it's not a common thing, but it can seem common to some people because they might have seen it quite a bit. But it is quite problematic if somebody gets it. It's an ER trip, and hopefully you can do airway management, get the person out in time before they totally obstruct and not intubate them. But anyway, the point is that it's a medical emergency if they do get angioedema. So if that does happen to somebody, we don't use ACE inhibitors, and we actually don't use ARBs either. We wipe out the whole class because there is some small cross-reactivity there that people who have reacted and gotten angioedema to an ACE inhibitor are more likely to get that with an ARB as well. Other side effects aren't substantial. Renal dysfunction, I'll talk about this more in a second, but you can get some different problems in the way that the body processes urine through the glomeruluses, and you can end up with possible kidney dysfunction. Usually with an ACE inhibitor alone, you don't see that. And in fact, ACE inhibitors are thought to be renally protective for most patients with diabetes or early stage kidney failure or early stage kidney disease. ACE inhibitors can cause transient increases in potassium, and they can cause a transient increase in BUN or serum creatinine. However, usually these aren't clinically significant. Beneficial effects, talked about that already. One thing I will point out that I forgot to mention on this slide is that what happens with, you can see this chart in red over here with the angiotensin 1 to 2 getting inhibited. The other component that's important is that ACE also breaks down something called bradykinin. Bradykinin is another vasodilator. So you'll notice that AT blockers don't do that, or ARBs do not block bradykinin degradation. And so one of the things that's thought is that because ACE breaks down bradykinin, if you're inhibiting it, you're going to have more circulating bradykinin, which one, causes you to cough, works in the lungs. Two, it's another natural vasodilator your body makes. So by getting more of that out, it's thought that you can have better impact on the cardiovascular system. And remember, we want those vasodilators. So AT1 blockers, this is going to go and break down through its normal pathway because you aren't doing anything with the actual enzyme. And in fact, some people will say that if you block the receptor, you upregulate some of these processes, and you can end up upregulating ACE because you want to convert more to angiotensin 2 because your body's like, why aren't you working on the receptor like you want me to? And then you can end up degrading more bradykinin. So there's some theory behind that. Anyway, I'm getting into the weeds a little bit on the pharmacology, but you guys get the points that ACEs have a little bit of an advantage there from a mechanism perspective than the ARBs do. These are ACE inhibitors, and again, they all end in pril. They're pretty straightforward. There's not really a difference in any of them. There's no study saying one's better than the other. Lisinopril is the most commonly used one by far. It's usually dosed once daily, although sometimes twice a day. But all of them are used to certain extents. I think I would always start with lisinopril just because it's well known, it's common, it's cheap. The rest of them have varying degrees of success. As far as dosing, interval might be different, or they might be more expensive. Problems with ACE inhibitors, they are contraindicated in pregnancy, so that is one thing with our patient population we aren't going to use them in, and use cautiously in patients with compromised renal function. So one of the reasons is somebody has on board with an ACE inhibitor, you end up with this afferent arteriole cannot constrict, or the efferent arteriole, excuse me. So what happens is, let's say you've got blood passing through the glomerulus, you're making urine, you've got good pressure in here. This efferent, so the efferent arteriole leaving the glomerulus, is going to have a somewhat constant constrictive effect so that it generates pressure within here. If you give somebody an ACE inhibitor, it tends to relax this, and what happens is they can lose pressure here. Now, in the short term, that can be nice for patients who have kidney disease, and you're trying to preserve their kidney function. It can be beneficial for them. But the problem is if you cut off supply here, you end up with no pressure in the system at all, and that causes kidney injury. So if somebody is dehydrated, for example, or if they take a non-steroidal anti-inflammatory medication like an NSAID, like ibuprofen or naproxen, that can constrict this side. And if this side's constricted and this side's open, you get no pressure in the system. Again, that can cause kidney injury. So while ACE inhibitors by themselves are not generally harmful for the kidneys, what is harmful is if you combine ACE inhibitors with volume issues, so hypovolemic status, dehydration, and or NSAID therapy. Those three things I think of as the triad for giving somebody an acute kidney injury. Okay, to continue talking about angiotensin receptor blockers, the other major category of drugs in this group. Again, these are pretty much interchangeable with ACIs. We did talk about some of the differences, and again, they don't break down they don't interfere with bradykinin's breakdown. So it gets broken down normally. Therefore, it does not have the cough associated with it. So this is the first drug you'd switch somebody to if you started them on an ACE inhibitor and they happen to have a cough with it. Angioedema by itself is quite rare, but there's a 10% cross-reactivity again, so we don't give this to people who have had the reaction with an ACE inhibitor. Basically, if you have angioedema to a drug in ACE or an ARB, you rule out this entire group of medications. You don't use them in combination. Again, I said that already. Names end in sartan, so like valsartan, losartan. We're going to talk about those in a second here. Here they are. Losartan and valsartan are the two generic options. The other three are the other four, excuse me, are brand name and more expensive. I did say that these have gone on shortage recently because of a big nationwide recall, especially tied to valsartan. So it's created some problems with the marketplace, but otherwise they're usually pretty available, and losartan and valsartan at least are quite inexpensive. Direct renin inhibitor, I'm just going to mention this. This is another option in this class. It's a single drug. There's not more than one in the category, and it would be an option to consider for people who have not had good tolerability to the other ones. So some people might think of this as a possible option for an angioedema patient if you really needed something in this class. But again, that's not totally well established whether that has a good cross-reactivity or not. It's quite a rare drug, so anyway, I don't really expect you to know anything about it other than that it exists. And aldosterone antagonists, not going to talk about these because they really have a role in heart failure, not really one in hypertension. I think the big thing to mention here just is that these sometimes can be considered potassium-sparing diuretics, but they have weak diuresis compared to some of the actual diuretics we're going to talk about in a second, and really don't have a huge role in anti-hypertensive therapy. They're listed here for this purpose, and in heart failure they do have a role, but we won't talk about them here. Moving on to diuretics. Diuretics work in the kidneys and at multiple different stages depending on the different drug. They all essentially do the same thing. They remove excess fluid from the body. How they do it is going to be different, and how they change electrolytes be different. Basically, the idea here is you're manipulating the way the kidneys remove electrolytes, and then that's going to cause water to follow it, which is going to end up with diuresis. And you decrease volume, you decrease blood pressure. That's the whole theory behind them. Diuretics are some of the oldest drugs we use to treat hypertension, and they're also some of the most effective. Thiazide's diuretics are some of the mainstay historic treatments for hypertension. They've been around for the longest period of time out of any of the drugs we're going to talk about today. They're still really relevant. They started out with really high doses, and people had experience unwanted adverse effects with them. The doses have come down historically, and we're at a point where actually it's been proven that thiazides, when you increase the dose, you actually get some diminishing returns with them. So usually you get the biggest bang for your buck with your starting dose of your thiazide, and increasing it off of that tends to not necessarily have a huge impact on blood pressure, although it has some impact, but it has more of an impact on the electrolyte disturbances. Remember, all diuretics waste electrolytes or do something to electrolytes. So it's really important to remember that from a side effect profile, because that has to do with how you're going to monitor them. So for example, thiazide diuretics inhibit sodium resorption in the distal tubules, so they're going to increase serum sodium, and they're also going to increase water excretion and sodium excretion. So they get rid of sodium, they're wasting sodium, and they also waste potassium and hydrogen ion, but that's to a lesser extent. They do retain some calcium as well. Some people think that these might be a good option for people who have osteoporosis, because serum calcium might elevate a little bit. However, that's a little bit of a stretch in my opinion. Adverse effects: frequent urination, ineffective with low creatinine clearance, and hyponatremia. Those are the three big ones I think about. I think of frequent urination as a side effect associated with for people who just, as some things people are going to report to you as intolerability. So they're going to say, you started me on this new drug, I've been peeing all day, I can't tolerate that, I have to be up and mobile, and I'm out and about, and I can't always find a bathroom, it's not working for me. That's one reason, personally, I'm not a huge fan of these drugs right away. Again, they're recommended by the guidelines, they're certainly effective. I would just prefer, if you're going to give something to somebody, the side effect profile of the urination. Now, some people might tolerate it just fine, but for a lot of people it's going to be a little bit annoying. So just consider what their job is, and what their average day is, and how easy it would be for them to get to the bathroom throughout the day, because they will have increased urination. That's something to consider. I put the ALHAP trial in here. It's kind of a landmark anti-hypertensive review, and what they did was they looked at, it's an older trial, but it's sort of a famous one. They looked at low-dose thiazides compared to amlodipine and lisinopril. This is when amlodipine and some other calcium channel blockers were out, and there were a lot of new ACE inhibitors coming to the market, and they're all saying kind of they were the new best thing to hit hypertension since diuretics, and diuretics were not quite as effective. And then this trial showed that, yeah, actually diuretics are just as effective as these newer therapies. Now, all these therapies have been around for quite a while and are well studied to be good antihypertensive. And again, they've all made it into the guidelines as first line, so you don't really have to worry about that anymore, but it just goes to show you there is some evidence comparing them, and the evidence has shown that they're all equal, really, as far as classes go when it comes to being antihypertensive therapies. So from efficacy point of view, it doesn't really matter where you start, whether you pick an ACE inhibitor or a thiazide, assuming there's no compelling indications. What does matter is how your patient's going to tolerate the medication and if they're going to be compliant with it. So that's why I like to point out things like frequent urination, because I think it's something people are like, oh, I just prescribe a thiazide diuretic. I think one of your books says to prescribe thiazides first line, and it's just something that has a effect with it that a lot of people might not do great with. And it's not like they're going to get injured from it or get hurt. Maybe they will if they're elderly and they get up and use the bathroom at night and fall or something. You could use your imagination. But the point is that you have a drug class that does have a little bit of a complication there. So that's just where I'm coming at when I talk about some of these intolerances, because again, when you're trying to pick the first one, the guidelines say they're all acceptable. 2 drugs in this class, well, 3 technically. Hydrochlorothiazide is the most common one. It's lower potency, and it's for the vast majority of people the one you're going to pick. Chlorthalidone is the one that actually was studied heavily as far as thiazides go. So from an evidence perspective, chlorthalidone has more evidence. However, it's also more potent. So you end up with increases in sodium wasting with chlorthalidone. In my ED career, I've actually seen a couple people come in with critically low sodium from chlorthalidone starts alone. So it can actually have a pretty profound effect. It also has a longer half-life. So you've got a more potent drug that sticks around longer, which is why most people are more comfortable with hydrochlorothiazide. It's going to be the more common one you see. Certainly chlorthalidone is an option. And if you're getting some results with HCTZ, you could try chlorthalidone if you wanted to increase the potency a little bit. Maybe you're already at a decently high dose of HCTZ, and again, you don't want to push the dose too high. But switching it to chlorthalidone might be an option for some patients. Latolazone isn't an antihypertensive. It's used to augment diuresis for heart failure or kidney disease and to get extra fluid off. It's a really potent thiazide diuretic, and it's relatively short acting, so we don't use it chronically for hypertension. Loop diuretics, again, these are similar to latolazone, not for mechanism. They're a different mechanism of action, but they're short acting, they're potent diuretics, and they're used for fluid removal only. These are not antihypertensive. However, by removing fluid, you're going to get some antihypertensive effects. It's just going to be more beneficial for other diseases, again, like kidney disease and heart failure, really not relevant to hypertension. Aldosterone, non-aldosterone potassium-sparing agents, triamterene and amiloride. The only reason I'm mentioning these at all, these usually aren't used as monotherapy. Generally speaking, they're combo drugs. So you see a lot of people on combinations where they're on like a combination hydrochlorothiazide, triamterene, or lisinopril, triamterene, or something like that. And the reason is that some of these drugs can decrease potassium. These drugs can, and then if you add on triamterene or amiloride, they can negate that effect of those other agents that we've already talked about. So you'll see a lot of combinations out there. Whether they're really worth doing or not, I don't know. If you have somebody who's transiently kind of dropping in their potassium due to diuretic therapy or due to ACE inhibitor therapy, it might be worth trying a combo. That way they don't have to take 2 drugs. It can take, or not 2 pills, excuse me. It'd be 2 drugs in 1 pill, so it decreases their daily pill burden a little bit. But other than that, it's not, I don't know if they're terribly effective, but they are options out there. But generally speaking, again, not used for monotherapy. Calcium channel blockers are the other major class that's recommended first line in the guidelines. There's 2 different categories here, and it's really important to know the difference. There's the dihydropyridines. They all end in dipene. They're potent vasodilators, and they act peripherally. They have very little to no effect on cardiac contractility. The other types of calcium channel blockers are non-dihydropyridine. They really don't have a huge effect as vasodilators, so they don't really work peripherally, but they work mostly on the heart and they control rate. So very different things. We use the non-dihydropyridines for rate control. We use the dihydropyridines for blood pressure management. Just a quick review. calcium channels, when they're blocked in the heart, cause an effect on slowing the SA node conduction, and when they block calcium channels in the arteries, they actually have a dilation effect. So it's just two different systems and similar molecules, but the dihydropyridines are just designed to work on the receptors in the peripheral vasculature, and they don't really have much of an effect on the heart. So these are the ones we're talking about when we talk about antihypertensives. Amlodipine has been the most common one and been around for a while. It's probably the one that most people are most familiar with. However, nifedipine is really popular in OB. It's actually used a lot as a first-line agent for hypertensive emergency even. There's some interesting studies that show that if you give it at the same time as you give even some intravenous antihypertensive agents, it works just as fast orally as some of the IV drugs do. So it's great if you can't get IV access, or if you're trying to get somebody's blood pressure down quick and that's all you have access to. It's a really popular choice for obstetrics. So if you've worked labor and delivery, you've probably seen this drug a million times. But the more common one in the general population is amlodipine. It's the one that most people are going to be taking chronically as an antihypertensive. I'd really just care about amlodipine and nifedipine for these ones. The other ones all have varying capabilities, but those are going to be the two ones we see most commonly used in the general population. Side effects these are pretty well tolerated medications. They have a headache, dizziness, lightheadedness, flushing, and peripheral edema, mostly associated with their vasodilation properties. Don't worry about heart failure use. We aren't going to talk about that for this course. That's just in here. It's part of my slide set. And they are highly CYP3A4 metabolized. And the reason that's important is because they're prone to drug-drug interactions. So if you have something that manipulates the CYP system, you can easily get too much of this on board. You might see excess hypotensive effects. These can also interfere with the metabolism of other drugs. So like, for example, if you give them with a statin, like simvastatin, you have to dose restrict it, because otherwise the statin can cause negative effects because it's interfering with its metabolism, because they're trying to get metabolized by the same enzyme in the liver, and the liver only has so much enzyme. So if you have two drugs trying to go down that same metabolic pathway, you can only do so much with it, and so you end up with higher concentrations of both. Most drugs are pregnancy category C, as I talked about. Nifedipine is commonly used in obstetrics. However, it's likely that amlodipine is fine too. It's just not very well studied. I'm only going to spend a couple seconds on non-dihydropyridines just because they don't have a huge role in what we're going to be doing. Diltiazem is pretty much used as a rate control agent only, so we use it in arrhythmia. And verapamil has some role in some other things outside of cardiovascular medicine, so it's used as like a migraine prophylactic agent. However, it can be used as an antihypertensive. It has some more peripheral vascular effects than diltiazem does. Diltiazem really just works on the heart. Verapamil I've seen used for hypertension, but it's sort of a last line agent. So you've probably tried a bunch of other stuff and then you try verapamil. Basically, again, that's all I really care about you knowing. Otherwise, the roles are purely for rate control, which is a bit beyond our scope for this course. And I'm going to ignore the side effects because they aren't super important for us to talk about. Okay, beta blockers are usually third or fourth line depending on what other medications you've tried, what you're doing. They are effective antihypertensives. They end in the term, the letters LOL usually, and an example would be propranolol I've got there for you. Adverse effects are usually why they're limited. So beta blockers work primarily on the heart and they decrease heart rate. That can make people feel a little bit uncomfortable. It can make people feel tired. There's actually some reported mental illness-like symptoms too. People can feel depressed or just not themselves on beta blockers. And because of that, these have sort of pretty much fallen off the guidelines as a first-line agent. Really, we're going to use the other ones before we try these. Now, there are some exceptions, but for the most part, these are not going to be recommended initially for just standard hypertension for patients. Older drugs tended to be non-specific, meaning they hit lots of different beta receptors. There's beta receptors in the heart and the lungs and other places in the body as well. So if we can get a beta blocker that's receptor specific to the heart, that's going to have the most effects on the cardiovascular system with minimal side effects. If it affects the lungs as well too, that can cause some respiratory issues, especially for people who have asthma or other respiratory conditions. Here's some examples of beta blockers. I kind of bolded the ones that I think are most commonly used. Atenolol, carvedilol, labetalol, metoprolol are probably by far the most common ones out there. The other ones have some roles here or there, but not super popular. Okay, let's talk about how we manage hypertension. Essentially, just like anything, you're going to mix and match classes to get the effects you want, and don't double up on your class. Monotherapy is the best way to start and will normalize blood pressure in about 30 to 50% of patients. Usually you could consider 2 drugs right off the bat if the person is more than 20/10 systolic, diastolic above their goal. And the majority of patients will likely require more than 1 agent if significantly above goal. So it's not uncommon to have people on multiple drugs. It's just in a lot of cases you're going to try to start with one and keep it simple and optimize that one. Always make sure your doses are appropriate too. Get that dose optimized before you add another agent on, or at least get it to the point where the patient isn't having any adverse effects. Sometimes we can't get things to the optimum dose because somebody has side effects, but we try to get it as optimal as possible. Again, I've kind of mentioned compelling indications. This is just more for your information. It's a little bit outside the scope for this class in a lot of ways, I think, but there's some other information there. This is an old thing from the JNC7 guidelines, but it's still pretty applicable, and it shows you the different conditions and sort of what's acceptable for them. Other hypertensive therapies. There are a couple of other drugs available. So alpha blockers are an option. This would be more applicable to male patients, I think, older male patients. So again, a little outside of our wheelhouse here, but for primary care purposes, let's talk about it for a second. Alpha blockers have effects on the prostate as well, and they can help, oops, too far there, but they're pretty limited due to their orthostatic effects, so they cause some postural hypotension. And really, the only time you'd use these for as an antihypertensive is for a male who has benign prostatic hyperplasia, and also you'd want to lower their blood pressure, and that's their primary role for managing hypertension. Clonidine and hydralazine are 2 kind of oddball drugs that don't really have class. Clonidine is essentially acting alpha-2 agonists. So we just talked about alpha blockers, right? These are peripheral alpha blockers. Clonidine works in the central nervous system to agonize alpha receptors, and what that does is it causes a downstream effect, which ultimately lowers blood pressure and decreases sympathetic tone. And it comes as an oral tablet, as a transdermal patch. It's actually very fast-acting when taken orally. It's a good one to bring blood pressure down quickly if you don't want to give somebody an IV. Side effects are pretty significant for a lot of people. People feel drowsy or fatigue, headache, kind of similar to a beta blocker. Hydralazine is a direct arterial vasodilator. It's fast-acting as well, even when given orally, and it's got some flushing-related side effects. People can also experience angina because it can expand those arteries in the heart too, which can cause some chest pain type sensations as well. All right, let's talk about pregnancy quick, just because that's the name of that's the name of the game. That was what I was going to say, but that's the purpose behind why a lot of you guys are doing this, because you want to be more involved with peripartum care. So I'm sure you guys have talked about some of this in another class already, but just to make everything fit in a little bit more here and just to review. Hypertension in pregnancy. So gestational hypertension is usually defined as 140/90. Without proteinuria or pathologic edema. Once you get to that point, you're looking at preeclampsia. After preeclampsia, eclampsia would be hypertension with tonic-clonic seizures associated. It's pretty rare to get to that, but certainly you can. And if you work at a high-risk place like Abbott, for example, we do a lot of cases like this, or we take a lot of higher-risk patients when it comes to hemodynamic stability. So we do see some eclamptic seizures here and there. Ideally, you can control this before they get to the point of an eclamptic seizure, but that doesn't always happen in the real world perfectly, right? Chronic hypertension in pregnancy would be existing before 20 weeks gestation. And there is some studies to show that chronically hypertensive patients are more likely to get preeclamptic. You just want to manage everyone the same way. Make sure you're controlling the blood pressure regardless of if they're a newly hypertensive patient due to the pregnancy or if they've been chronically hypertensive prior to their pregnancy. For hypertension management in pregnancy, these are the primary options that we're are mostly going to use. So it gets a little bit different here, and that's why I was saying there's some caveats with what we do as far as the guidelines don't necessarily apply to some of this. So methyldopa is a really old drug. It's actually similar to clonidine. And the only time it's ever used is in pregnancy. I don't think we use it anywhere else. And I think, honestly, it's fallen out of favor a fair amount in terms of using labetalol and nifedipine over it. Just because it's not as potent, it's a little bit sedating, and it's got a slow onset. When you compare it to a drug like labetalol, it's just not quite as effective. So the beta blocker labetalol has been studied in pregnancy and used in pregnancy for a while, and it's preferred agent. Metoprolol, which is a more common beta blocker, has also been studied in pregnancy and is fine to use too. So I think people get really hung up that you can only use like these drugs, and really you can probably use some other ones too, but most people will stick to these basics just because, again, that's what the OB community uses, and that's what's been studied. Calcium channel blockers like nifedipine are used very commonly. However, they have very little data for them. Even with nifedipine, the trials are very small. We don't know a lot about long-term risk or fetal exposure or anything like that. They're thought to be safe. A lot of these drugs, you'll look them up and they come up as category C without much evidence, and we just use them mostly because of anecdotal experience. We've done it in the past. It's worked. We haven't really had any major issues with it. Studies have shown retrospectively that there's not fetal malformations or anything like that, so let's keep going ahead and doing it. Some other, like amlodipine and some other, the dihydropyridine calcium channel blockers are also thought to be safe, but again, very little evidence for that. Nifedipine's common one. Nifedipine comes as multiple products too. It comes as immediate release and extended release, so you can give it and make it convenient. The nice thing about amlodipine, it's a once-a-day med, but nifedipine, again, has some extended release products that can get your dosing intervals down a little bit. And then hydralazine. Again, we just talked about hydralazine being its own class, but hydralazine is a drug that is well known to be relatively safe in pregnancy. It also comes IV and PO, so it's nice if you get into one of those like preeclamptic or eclamptic emergencies. Hydralazine is an option you could give. Oh, this is just a chart showing preeclampsia with severe features. I'm pretty sure you guys have access to this type of material, but I thought I'd just throw it in there since we're talking about it. For preeclampsia prevention, there's some other interesting things they do. Aspirin, 81 milligrams daily starting at the end of the first trimester. Preeclampsia is associated with increased platelet turnover, so this can have an effect at increasing clotting risk for patients. So aspirin can work against that. Its benefits are mild. The studies aren't great with it. It is an option sometimes people will see. So want to make sure you try and DC it 5 to 10 days prior to delivery. Give your body a chance to turn over platelets so that you can rebuild those. Treatment, deliver the baby. If it's appropriate at that point in the pregnancy, that should resolve your preeclamptic issues. Methyldopa, and then again, labetalol, hydralazine, nifedipine. I don't think our hospital really uses methyldopa very much when it comes to preeclampsia. I think labetalol and hydralazine and nifedipine, mostly labetalol and nifedipine, are the popular choices. For severe treatment, high-dose magnesium sulfate is used. Magnesium sulfate kind of works as a smooth muscle relaxant, and it causes some peripheral and cerebral vasodilation and blood-brain barrier protection, and it also has some general anticonvulsant properties. It's kind of cool. A lot of the studies have actually shown that this is more effective than like a benzodiazepine like lorazepam or diazepam, which are sort of the mainstay for status epilepticus treatment. And you could use that for an eclamptic seizure too, but magnesium is the one that's studied and we know the most about it, and it's the preferred agent. So it's kind of a unique role magnesium has in OB. For breastfeeding and hypertension, this is a question that comes up a lot, I think, with breastfeeding. Breastfeeding is really tricky. I know Katrina does a separate module on it, so I'm not going to talk about it a lot. But there's very little data on breastfeeding, and a lot of times you're taking a shot in the dark. You're looking at how much excretes into breast milk. And then I always ask myself, do kids take this medicine for various conditions? If it's approved for pediatric use, it's probably relatively safe for kids. And I always tell people to think about it this way. Think about all the ways that a drug has to get into breast milk. So it has to get through the GI tract, it gets to get absorbed, go through the liver and first pass metabolism. It has to get into breast milk. It's circulating in and out with concentration gradients and getting metabolized in the process various ways. it gets out of the breast milk and the infant ingests it. Then it has to go through their GI tract. It gets broken down and further metabolized by their first pass and their hepatic. And finally, a little bit gets into their systemic circulation. How much? Usually, in most cases, it's not a lot, but we still take it seriously, and we want to make sure we aren't exposing a newborn to something they don't need. So when it comes to lactation and hypertension, there's a couple studies out there. The idea is that there's some best and worst case scenarios here. There's not a lot of like firm recommendations, but this is sort of the evidence out there. For beta blockers, propranolol, metoprolol, and labetalol have all been shown to have the lowest amount of excretion of the breast milk. Atenolol has a higher amount, which atenolol is kind of a popular beta blocker. So if that's something one of your patients has started on and they're going to start a family or trying to start a family, it might be useful to stop it, because if they're going to continue it after their pregnancy period, probably want something else. Calcium channel blockers, your best options here. Diltiazem and verapamil, which we wouldn't really use, so you can X those off. But nifedipine and nicardipine. So again, we have our drugs that we like here, labetalol and nifedipine for pregnancy, for treatment during pregnancy. So it makes sense that they would be good for lactation as well. So it's a nice continuation. If you stabilize somebody during their pregnancy on labetalol and nifedipine, and you can continue that easily on to the postpartum period, which you couldn't necessarily do for some other agents. Or you could, but you'd be maybe risking a little bit more infant exposure. RAS drugs, you could resume an ACE inhibitor at this point. They're problematic during pregnancy, but really not huge post-pregnancy, and children can take ACE inhibitors if they are indicated. The best drugs are probably captopril and enalapril. But they can cause some hypotension and kidney injury potentially in infants, so they're a little bit less preferred. Diuretics have been thought to reduce milk volume just because they're having a dehydration effect on you, so they're generally avoided postpartum, from my understanding. All right, that's that lecture. I hope you guys enjoyed or learned a thing or two about hypertension. Feel free to ask any questions that come up, and we'll move on to the next topic.